Welcome to the Neurocritical Care Society podcast. My name is Joshua Levine, and in this episode, Dr. Jim Siegler will be interviewing Dr. David Coughlin on the paper he recently published in Neurocritical Care entitled Preventing Early Bouncebacks to the Neurointensive Care Unit, a Retrospective Analysis and Quality Improvement Pilot. Here's Jim.
My name is Jim Siegler, and I'm a Vascular Neurology Research Fellow at the University of Pennsylvania in Philadelphia. It is my distinct pleasure to welcome my friend and colleague, Dr. David Coughlin, also from the University of Pennsylvania, to the NCS podcast this week. Thanks for joining us, David.
Hi, Jim. Thanks for having me.
The study that your team put together is pretty unique as far as studies published in neurocritical care go, in that it was a quality improvement study. Can you give us some background as to what your research question was and how you came up with that question?
Yeah, absolutely. So the study is a bit unique in several ways. So we use sort of a hybrid approach where we use some traditional research methodology, but also started interweaving a lot of quality improvement methodology as well, especially when it came to the implementation of the pilot. So there are different philosophies behind how you would approach these different types of questions with these different types of techniques. You know, we're all much more familiar with the idea of proposing a hypothesis as a research question, whereas quality improvement instead tries to take a perceived problem, understand it in pretty good depth, and then design and implement the solution in fairly short order. And then you're supposed to track its implementation and continue refining it sort of in real time. So ultimately, our goal was fundamentally to use the information that we had from our local experience in our own neuro ICU to help design this quality improvement pilot within sort of the workflow of our own day-to-day in the neuro ICU to help strengthen the transitions of care for this potentially high-risk population in the hope of decreasing bounce backs. So the original start of this project ultimately was inspired, I guess, by a particularly bad call night that I had when I was a junior resident, and there were 8 ICU transfers from the NICU to the floor between the hours of like 6 p.m. and 6 a.m. And it was a really, really busy night. I felt like it was stretching sort of the limits of safety. And of those 8, we did end up having to send 1 back to the neuro ICU for respiratory distress and increasing O2 requirements. But it was really that night that sort of started me thinking about the questions sort of regarding safety in ICU transfers in general.
Now, you've mentioned this concept of patients bouncing back into the neuro ICU or calling them bouncebacks. What makes a bounce back transfer any different from a typical transfer for a patient from a lower level of care to a higher level of care?
It's probably useful to go over just some definitions, and because those definitions vary even across the quality improvement literature for this. So a bounce back is generally thought of as an unplanned readmission. In this case, back to the ICU. Now, you can define a variety of timescales for which to qualify as a bounce back. You know, in sort of the broadest sense, we've all heard about 30-day readmissions, which is its own type of bounce back. In our study, we use 48 hours as the defining amount of time to qualify as a unplanned neuro ICU bounce back anyway, and this was actually chosen based on some empiric measures that different studies had used to define sort of the optimal amount of time to qualify as a bounce back. But to answer your question about what makes these people different, the majority of literature about the subject comes largely from surgical units or from combined med-surg units, and most of them report that bounce-back patients have a longer length of stay, greater mortality, greater overall health care costs in general, and this is true even when you control across other factors like illness severity. And ultimately, some bounce backs may not be preventable and are really just progression of a primary illness or a secondary unavoidable consequence. But one of the inspirations for this project is that many of them probably are preventable and are maybe a reflection of a health system's failure to identify and properly care for these patients in the correct setting.
I want to go back to that concept of medical readiness for transfer a little bit later, but first, could you briefly summarize the methods that you used in the pilot study?
Sure. So we had input from physicians, nurses, and respiratory therapists who worked on the floor and also the team that worked in the ICU. What we ended up designing as what worked for us was that on the day of transfer, the physician who was the primary caring provider for a given patient would fill out this one-page checklist that would define a patient as either high risk for bounce back or not. They were labeled as high risk during the pilot if they had any one of the what we call high risk features. If they were labeled as high risk, they would integrate that into their doc-to-doc handoff. They would also inform nursing, who would use that in their nurse-to-nurse handoff, and the same thing for the respiratory therapists. Physicians would be able to mark them as high risk in our bed transfer system in the electronic system that we have going on. And when patients hit the floor after they moved to their new bed, automatic pages were sent out both to the covering senior resident on the floor as well as the covering respiratory therapist. And we had a goal that high-risk patients would be evaluated within an hour by a physician, within 2 hours by a respiratory therapist.
So after you did this retrospective chart review, you then implemented this quality improvement tool as a checklist to determine medical readiness for transfer to the lower level of service. However, in the paper, you showed that there were several stages before your team was really able to effectively implement this tool, or at least there were different degrees of improvement as the trial went on. Can you walk us through how you planned these stages and why they were necessary?
Sure. So it wasn't really our original intention to have this tool as a marker of medical readiness for transfer, but I would hope that if several risk factors were being checked, that it might prompt some consideration about readiness by the primary ICU team. The staged rollout was definitely intentional and was done for many reasons. There are a lot of working parts with a number of different types of groups involved, both, physicians, nurses, respiratory therapists are sort of the big groups. So we felt that it would be easier and allow us to refine the process a bit more if we did it in sort of a staged format. We had the most buy-in from the physician group, and they were willing to work with us, both the ICU physicians and the floor physicians, so we started with them. And, we learned a bunch in the first 3 months, and it was, surprising stuff sometimes, like we had issues with people losing the checklist upon transfer initially. We even found out that we had to make these little bins that would travel with the physicians on their computers on wheels station to help encourage them to fill it out in a timely manner at the time when they were thinking about transferring a patient. There are all these little things that we only discovered when we started implementing things, but really allowed us to make things smoother, especially when we were rolling in like the next group of people. The nurses did very well, the respiratory therapists were brought on when things were very smooth at that point. One of the reasons that we ended up adding respiratory therapy at the end actually was because they were concerned about the volume of work that this was going to add to their already pretty busy burden that they have to deal with in the hospital anyway. So we tried to make sure that their involvement was as directed as possible. So there are all sorts of considerations, but ultimately it boiled down to making sure that we could do refining of the process on the go and making sure that we were respecting all of our stakeholders' wishes.
One of the results in particular stands out to me, and that's the selection of your outcome variables. While there was no primary outcome variable, as this was kind of a quality improvement initiative, the first outcome of interest was the incidence rate of bounce back events. In your opinion, is a lower rate of bounce back better? And if not, what would be the optimal rate of bounce back events?
Also, a very excellent question. So we talked a little bit a while ago about the heterogeneity about bounce backs in general. So you're right to bring this up. An optimal bounce back rate is almost certainly not zero. You can even imagine that type of practice would lead to keeping people in the ICU for impractical amounts of time and leads to a whole different set of problems with resource utilization. I suppose you could say that this may end up being sort of analogous to what we think about regarding extubations, where a certain number of reintubations are tolerated, especially if you're going to encourage patients to kind of, quote, fly after extubation. In fact, moving a patient who becomes acutely ill back to the ICU in some cases is probably a marker of really good care in some cases. But ultimately, we're hopeful that this tool and process was going to help decrease the number of preventable bounce backs, which is why we were looking at the overall rate as an outcome of interest. And we were close to demonstrating significance at the end of this pilot, but also the tool worked very well. It was a potential marker of those who may decompensate for any reason, which was an encouraging finding as well.
What were some of the limitations you faced in your study?
The study has several limitations. One was that we performed using only neurology patients, even in spite of the fact that most neuro-ICUs manage both neurology and neurosurgical patients. There were a couple reasons for this. Mostly that in our unit, the neurosurgery teams that serve as surgical primary care providers have a much different workflow and would have required probably a parallel and very different type of pilot to extend to their group. Honestly, actually, they have started to adopt this now with some modifications that make more sense for their timing and what they do around their own transfers. The fact that we were using our own sort of homegrown data from the patients that we had seen bounce back in the last 2.5 years, we used those things to design our original tool to identify people as high risk. Now, in somebody else's hospital, their population may be a little bit different. They might have different types of risks. You might end up with different risk factors that make more sense for your particular hospital than what we found here at the University of Pennsylvania. Ultimately with our design, the risk factors that we included in the pilot sheet were chosen after this chart review. We did not try to match them to patients who didn't bounce back. This is generally meant to foster a higher sensitivity and to make sure that we were paying attention to the patients who we felt were more likely to compensate. Another problem that we generally had just with the stats was that generally the bounce back rates for both the retrospective portion and during the pilot were very low, which makes comparison difficult just because of floor effect things, which may be part of the problem with us being able to, or really not able to demonstrate a P less than 0.05 significance. And ultimately, we were a little bit limited in the time that we were able to perform the full pilot study, just because of how much time we were able to get from the respiratory therapist to participate.
My next question for you, Dr. Coughlin, is what should the listeners take away from your study, and how can they effectively work to implement a similar quality improvement tool at their own respective institution?
Yeah, sure. So we used our own local experience with our neuro-ICU bounce back to design this tool to help identify folks who we thought were a particularly high risk for bouncing back soon after transfer. We found that respiratory distress / hypoxia and sepsis / hypotension were the two most common reasons for bouncing back. While this is in line with other studies that have looked at different populations, it's possible that other institutions may have different types of patients and different types of measures that would be more important for them to look at. We designed our intervention based on several local factors and tools that were available to us. And we took several cues from other types of similar interventions that were taking place elsewhere within our own healthcare system. I think that a few major take-home points about designing quality improvement initiatives would be to make sure that you understand as much of the problem as you can. And that doesn't mean just doing the retrospective analysis like we reported, but we also spent a fair amount of time observing what happens around the time of transfer and where potential weaknesses might lie with information communication and the decision-making and determining whether somebody's ready for a lower level of care or not. I think that if people engage in that type of observation, you can be surprised about and find areas for intervention that might not have occurred to people otherwise. You also definitely want to make sure that you have input and buy-in from as many people as possible, as many stakeholders that you can think of. We talked a lot in the paper about the involvement of physicians, of nursing, and respiratory therapists, but there was definitely other groups involved. Like we had IT that was involved in a build to add some of the automatic text page system. Believe it or not, we actually had our unit secretaries that were involved as well to make sure that we were capturing as many of the bounce back sheets after they were used for analysis later. So, it can be pretty extensive, and just observing your own process while it's happening can help you identify these little things, and small tweaks like this and perpetual improvement really help things go a lot smoother. This type of approach is a lot different than what we usually do in clinical research, and this study is ultimately a hybrid of several different types of methods, but it has been popular, at least amongst the neuro-ICU folks here at the University of Pennsylvania, and it still is continuing now, actually.
Well, I certainly think that there's a lot that we can take away from this study, and as I was a participant in the trial back when I was a resident at the University of Pennsylvania, I can certainly attest to the simplicity of the tool, the pragmatic design of the research and the quality improvement initiative, and the efficacy that it demonstrated. Thank you so much for your time, Dr. Coughlin. I really appreciate you joining me on the show today.
Absolutely. Thank you so much for having me.
That was Dr. David Coughlin from the Hospital of the University of Pennsylvania. You can read his paper titled Preventing Early Bouncebacks to the Neurointensive Care Unit, a Retrospective Analysis and Quality Improvement Pilot in the journal Neurocritical Care.
This podcast is produced by the Neurocritical Care Society, whose mission is to promote quality patient care, professional collaboration, research, training, education, and advocacy in neurocritical care. The Neurocritical Care Society provides and advocates for the highest quality of care for patients with critical neurological illness throughout the world. Follow us on Twitter @Neurocritical, on Facebook, or visit www.neurocriticalcare.org for more information about NCS and the comprehensive resources that it offers. On behalf of the Neurocritical Care Society, thanks for listening.